Good day, guys. This is Dr. Mathai with Oregon Health Direct Primary Care and Vitality. Thank you for joining us today. I hope this webinar is as useful to you as it has been to a lot of our patients. One of the things we often talk about in our clinic is what is aging. And you can look at aging through a couple of different lenses. You can look at it from the lens of a psychosocial model, a social model, or a physiological model. So today we'll be chatting a little bit about aging as it pertains to human physiology and really looking at cellular functions from that perspective. The way I think about aging is a decline in cell function. So as time goes on, there's various things that will cause our cells not to function as well. And what we end up seeing on the external is what we typically call aging. One of the things that is pretty common as cellular function starts to go down is hormones, which are very powerful signaling molecules that our bodies produce, actually starts to go down. So today we'll be chatting a little bit about some of the hormones that we start to see as part of that cellular aging. And so when I think about aging, I actually think about cells starting to decline in function. And there's various things that can actually cause this. Genetics determines a lot of it, but lifestyle also plays a big role. When we start to look at hormones and their functions, and really when we look at optimizing it, what we're looking at is how do we use hormones to optimize cellular function to really help with aging gracefully, so to speak. The other question is, what are hormones? Hormones are very powerful chemicals or molecules that are secreted by certain tissues or organs in our body, and they play a role in signaling either within that tissue or outside of that tissue. So hormones can range from different things, including hormones that are used in regulating metabolism to what we'll be talking about today, which are what we call our sex hormones. So when we talk about optimizing hormones, and I'll chat a little bit later about what exactly that entails, there's a number of hormones that I typically tend to look at and that I think are important, especially when you're looking at optimizing aging these hormones are cortisol, your thyroid hormones, your sex hormones, which include progesterone, estrogen, and testosterone, growth hormone. And so these are the main hormones that we typically tend to look at, and there's various ways we can look at optimizing those. So the first hormone that I usually take a look at is cortisol. So cortisol is what we call our main stress hormone. It is actually one of the most important hormones required for survival. Without cortisol, we actually cannot live. We actually produce cortisol throughout the day. One of the issues that we tend to see actually in modern day life is that we have so much stress and strain on ourselves, on our physiology, that we have unregulated cortisol metabolism, or rather cortisol production, which can cause all sorts of rampant health issues. But the main thing is that cortisol is a very important hormone that we have to produce on a daily basis. The dysregulation happens when you're either producing too much at different times or too little when you actually do need it. There's a couple of functions of cortisol out there. So a big one is it helps with maintaining blood sugar. It's really important in immune modulation. It's a big hormone that our immune systems actually typically tend to use. It does increase during times of stress. Again, the problem with most of us is that those stresses never go away, so we have unregulated upregulation of cortisol. So typically, too much can typically lead to conditions like diabetes, hypertension, bone thinning is one of the things we tend to see. When you have too little, you have issues with things like fatigue, hypoglycemia, and there's certain autoimmune conditions that can also result from too little cortisol. So again, it's a question of really trying to find balance or fine-tune that cortisol production. I have a slide here that actually shows what a normal cortisol curve is. And again, like I said, you actually do produce cortisol throughout the day. The issue comes when you're either producing too much at the wrong time or too little at the wrong time. So our biggest cortisol burst, as you'll see on the slide, is typically in the morning because waking up is stressful. And so we tend to produce the most cortisol typically in the morning. And we see a nice rise in cortisol as the day starts, and that should typically start to go down as the day ends to allow you to actually get into sleep and restfulness. What I typically will see with dysfunctional cortisol is, especially people who have issues falling asleep at night, is they tend to have these bursts of cortisol later on in the evening, which then starts to impact a lot of other hormones, including melatonin, and that tends to impact how they sleep. chronic unmanaged stress is what typically tends to lead to unregulated cortisol. Initially, we will sometimes see cortisol levels being extremely high. Potentially with time, you can actually start to sort of burn out how much cortisol you're actually making. And so you can start to see in later stages of chronic stress is where those cortisol levels start to come down. What I tend to tell most of my patients, especially if in the situations where the stresses are unavoidable, is what can we then do to either manage or mitigate the stresses. So again, in our clinic, we talk a lot about things like meditation and yoga as ways to help manage stresses that you might not otherwise be able to avoid. We have this class of hormones that we call our steroid hormones. They are actually all formed from a molecule which a lot of you might actually think is bad for your health, called cholesterol. So cholesterol is a really important molecule that we use to form a lot of our hormones, including cortisol. So cortisol is a big one. Within that group of steroid hormones, we actually have progesterone, which is a sex hormone, which we'll be talking a little bit about. We have estrogen and we have testosterone. So all of those are actually formed from this base molecule called cholesterol. The issue with chronic unmanaged stress is that you start to increase the amount of cortisol that you need as the body says, hey, listen, we gotta survive, and cortisol is a survival hormone. And so you start to increase the amount of cortisol that you're making. You have a limited amount of raw material in cortisol, so you start to shunt from other pathways, and so one of the first hormones that starts to go down is progesterone. Eventually, estrogen and testosterone also start to go down. And the way the body looks at it, it says, hey, listen, we need some of these hormones for procreation, but we need cortisol a little bit more in order to be able to survive. And so we will typically optimize for survival first and then procreation after. So again, in chronic unmanaged stress, one of the byproducts is you actually start to lower a lot of these other hormones as your body is just trying to survive. We try and manage stress as best as we can. Again, people have different lives, and so there are certain things that you can really start to do to try and help optimize it. Like I said, a big one is trying to get into meditative practices like yoga and meditation, which have been shown to help with cortisol reduction and cortisol regulation. Sleep is another big one. I tell people, if nothing else, try and at least prioritize sleep, 7 to 8 hours for most of us. And if you're having trouble with sleep, again, talking to a physician to see if there's something else going on like sleep apnea, which is interfering with sleep, is another big one. Another thing that a lot of my patients I have them do is there are certain herbs called adaptogens. Ashwagandha, roseola are a couple of examples of these. And what they do is they help the body with cortisol re-regulation. So again, if you're producing way too much, it tries to bring that back down. If you're not producing enough, it starts to kind of bring that back in range. And so again, there's a lot of things that we can do. Again, ideally, if you had no stress, that is optimal, but that is not most people's lives. And so again, it's all about trying to manage stress as best as we can. Next hormone we're going to talk about is thyroid hormone, which is formed in the thyroid gland, which is a gland located right around here in the neck. It is formed when we combine an amino acid called tyrosine and iodine under the control of a hormone called TSH that's produced by the brain. So brain produces TSH, sends that signal over to the thyroid gland, and then we produce what we know as thyroid hormone. Thyroid hormone has a big role in our metabolism, and so a lot of times we'll really try and optimize that in patients depending on lab values, as well as kind of look at what symptoms they came in with. For the most part, I typically tend to see that as most people age, once you get to about 65, we start to really see a change in what your optimal thyroid levels are. And again, that is very different from what the lab reference ranges are, and we'll talk a little bit later about lab values in terms of what optimal levels are versus what normal ranges are. There's a couple of main functions that thyroid hormone does. Like I said, it is really involved in metabolism, and the way it does that is it helps with what's called ATP production in what we call the mitochondria, which are the powerhouses of the cell. They also help with increasing activity of the adrenal gland. The thyroid hormone is also important in the synthesis of a lot of enzymes in the body. It is also needed for growth hormone formation, as well as some of the functions that growth hormone has in the body. So in order for growth hormone to work optimally, you actually do need functioning thyroid hormone around. And it has receptors in almost every single cell in the body. So again, thyroid hormone, really important hormone that we really want to work at optimizing, especially if, like I said, if your levels are suboptimal or you actually have signs and symptoms of hypothyroidism. So when it comes to testing, I talk a little bit about what we call suboptimal levels and optimal levels of labs. Typically what I tend to do when I do thyroid hormone labs, which I think gives us a much clearer picture, is we're looking at the signal from the brain to the thyroid gland, which is called TSH. We're also looking at the output from the thyroid gland, which is T3, which is your active thyroid hormone, T4, which is your inactive, and sometimes we'll do something called reverse T3. So whenever we look at all of these four hormones in conjunction, they give us a much broader picture, a more complete picture as to what might be going on. Again, it's standard practice with what we do, and again, really helps us get to the root cause for what's going on with a lot of our patients. We are using a lot of supplements in our clinic, really trying to make sure that patients have the adequate nutrients to actually make thyroid hormone. That includes things like iodine, zinc, tyrosine. So really making sure they have a solid supplement to help with this. If we actually have a patient who comes in and they are hypothyroid based on lab diagnosis as well as symptomatology, we'll usually go ahead and replace their thyroid with thyroid hormone. And there's a couple of ways you can do this. You can use what's called synthetic forms like levothyroxine. I've actually seen a lot of patients do better with what we call armour thyroid or NP thyroid, which are animal-derived products of thyroid hormone. And again, some people, maybe it's absorption, maybe it's utilization. There are some people who just do better on those formulations. There are some people who do better on formulations like levothyroxine. Again, really trying to individualize therapy for a lot of patients in our clinic. So the next big class of hormones that we typically tend to look at are what we call our sex hormones. Now, earlier on I talked about our steroid hormones, and within those steroid hormones you actually have the sex hormones, which are progesterone, estrogen, and testosterone. Now, a lot of women are always surprised to realize that testosterone is actually one of the hormones that they produce, and it's actually one of the most important hormones in women. It's also one of the ones that we often overlook and typically don't check because we do not think of testosterone as a female hormone. We tend to think of that as a male hormone, but it's got a lot of functions in the female body. So there's a couple of things that we tend to see as female sex hormones start to decline. And again, this is just a general overview. It's a broad overview. It's not really targeting any specific hormone. But one of the things we'll typically see as hormones start to decline in women is things like irritability, insomnia, some brain dysfunction. Fatigue is a big one that we typically tend to see. And from a physiological standpoint, one of the things that we measure in women over 65 is bone thinning. So bone thinning is directly correlated to loss of certain hormones, specifically estrogen. Loss of estrogen also tends to lead to what we call vaginal atrophy or thinning of the vaginal lining, which can result in a lot of things, including discomfort during intercourse, as well as recurrent urinary tract infections. So we have a lot of women who are older who will come in with recurrent urinary tract infections, and the treatment for that actually is estrogen treatment to help with the vaginal lining. One of the other things that we tend to also see as hormones start to decline in women is the risk for cardiovascular disease starts to go up. There's question as to whether there is a correlation with dementia. The jury's still out on that, but we definitely tend to see that. Now, when we're looking at women specifically, again, ages 40 to 65, let's drop that reference range down a little bit. Let's start at actually 35 to 65. One of the first hormones that starts to go down is progesterone. Now, again, there's various reasons for this. Like I said, stress being a big one, where the body will preferentially make cortisol. The first hormone that it's actually going to steal or that it's going to divert from is actually progesterone. As progesterone starts to go down, again, women ages 35 to 65 will have a general decline in all their hormones. Progesterone is usually falling a lot faster compared to estrogen. Now, estrogen and progesterone do this interesting yin and yang dance, right? One is the yin, the other one is the yang, and you really want to have sort of both of those in synergy, in balance. As your progesterone starts to fall down, even though estrogen levels are falling, you now have estrogen falling a lot slower than the progesterone, which you end up having what's called an estrogen dominant picture. So typically women in the perimenopausal phase will usually have this, what we call an estrogen dominant picture, which will typically include things like anxiety, irritability, maybe even some depression. Insomnia, decreased sex drive is another big thing that we tend to see during that phase. Women will also start to have issues with bloating, edema, thyroid dysfunction starts to happen as well during this period of time, in part due to that imbalance between those two hormones. The most common outward sign that we tend to see in women is their menstrual cycle start to change. So women will typically be pretty regular in the beginning. Once they start to hit that perimenopausal phase, they'll start to have cycles that are either too short, too long, skipping cycles, too little bleeding, heavy bleeding, and everything in between. And that's predominantly because progesterone is falling a lot lower. You now have this picture of estrogen dominance. Testing is an interesting and somewhat challenging thing in women. Men, it's a lot easier. We really don't cycle our hormones much. By virtue of the fact that women are cycling, that means hormones are actually going through cyclical changes throughout the month, makes testing a little bit of a challenge. So what we tend to opt for is, if we are working with a woman who is in her reproductive years, you really want to get a picture of that entire 28 to 34 day cycle. And so ideally what you tend to do in those patients is order what's called a salivary hormonal lab. It's actually 11 to 12 salivary samples that are taken over that 28 to 34 day period of time, and we can map out that entire month. In women who are in perimenopause, so again, anywhere from 35 all the way up to about 65, I'm not as concerned as what's going on over that cyclical period, because I know 99% of women will have a progesterone deficit. So I'm typically just doing labs on day 18. So if you have a cycle, count up till day 18 and really just checking labs between day 18 and 21 and really looking and seeing where those hormonal levels are at. Because again, we know that 99% of the times, the problem is going to be a progesterone problem. One of the reasons, especially for working with younger women, when we may want to take a look at the entire cycle, is actually fertility. So patient comes into our clinic, is really desiring to have a pregnancy. As part of that workup, is we really do want to know what's going on throughout the entire month, because really what we're trying to impact is fertility. Again, women who are 40 and above may not be looking for fertility. They're just looking for a way to alleviate some of these symptoms. When it comes to hormonal optimization, again, it's really looking at where the problem is at. And I said 99% of the times the problem is progesterone, and potentially adding a little bit of progesterone to help alleviate some of that estrogen dominance. Along with that, we are also adding a little bit of testosterone for patients, and a lot of it is really based on what symptoms they have and exactly what our outcome tends to be. Typically, when women are still cycling, so again, they haven't hit menopause, and by menopause, we mean that you have not had a cycle for at least a year. So again, if you haven't hit menopause yet, even though your cycles are irregular, I know you still have adequate amounts of estrogen, so we actually don't do anything with estrogen optimization at that point in time. All we're doing is we're trying to balance out what estrogen is doing with a little bit of progesterone and potentially testosterone, again, depending on what it is that's going on at that point in time. So I'll touch on this a little bit later, but one of the things we tend to see, especially when we're starting to replace hormones, and specifically testosterone, again, we don't think of testosterone replacement in women, but one of the big things we tend to see is testosterone really does help with mood improvement. It helps with energy. Again, it's one of those hormones that we don't think about as an energy producing hormone, but it really does help with energy. It's going to help women maintain muscle as well as bone density, which again is very, very important as we age. It also helps with decreasing fat as well as decreasing insulin resistance. And a big one that our patients really tend to like is that it does help with increasing libido, which again is important for a lot of our patients who seek our help. I alluded to this a little bit earlier, where and I always tell patients whenever we're testing, there's something called the tyranny of the lab report. Again, lab reference ranges are based on a sampling of the population. What I've seen over the last couple of years is that, especially when it comes to testosterone, is we've seen that goalpost kind of shift. A really good example is, again, not relevant for women per se, but a good example when you're looking at lab reference ranges is look at testosterone levels in men. So about 10 years ago, the normal reference range for testosterone in men was about 400 to 1200. Today, most labs are using 300 to 800 as your reference range. Now, one would ask, why has that reference range changed? Again, our reference ranges are based on sampling of a healthy population. And if you're continuously sampling a population that is getting unhealthier and unhealthier, that distribution of the norm starts to come down. And so a lot of times when we're looking at lab tests and, patients getting lab tests and coming back and saying, well, my labs were normal, especially when it comes to hormones, is I will look at what that distribution of the normal is within that reference range. So if the values are, let's take for instance, the lab value is 5 to 105, right, we'll try and take a look at, okay, where is the dead center of that reference range and see if we can optimize your levels to the 75th percentile. So again, we're not trying to take patients above that reference range. We're really trying to just figure out how can we get them to the 75th percentile and above and see if that impacts how they're feeling. So one of the most important slides that I actually had in here was HRT versus HST. HRT stands for hormone replacement therapy. HST stands for hormone substitution therapy. Two very different things. Whenever we think about hormonal replacement therapy, really what we're trying to do, and again, that's part of what we do with optimization, is if somebody comes in and they actually need progesterone, we will actually use progesterone to treat their symptoms. If somebody comes in and they need estrogen, we will actually use estrogen because that's what they need. Hormone substitution therapy typically involves using substances that look like the hormones but are not quite the hormones. Birth control pills, right? So birth control pills contain what we call progestins, which are not progesterone. And again, they do absolutely have their utility, but I'm typically very clear with patients when we're talking, about the distinct difference between the two, as that does play a bit of a role in terms of cardiovascular outcomes, heart disease, strokes, and things like that, as well as risks for things like blood clots and breast cancers and ovarian cancer. So again, I think it's an important distinction to make. So like I said, one of the things that we call HSTs is oral contraceptive pills. Now, don't get me wrong, oral contraceptive pills do have a role, but again, whenever we prescribe them, we need to remember that they are not hormone replacement therapy, they are hormonal substitution therapies. Again, they do have a role in certain clinical settings, but we have to remember that they do increase the risk of things like strokes and cardiovascular events. They do increase the risk of blood clots. They do increase the risk of things like breast cancer. There seems to be an association with an increased risk of diabetes and high blood pressure, as well as certain autoimmune conditions like lupus, as well as certain liver tumors whenever we use oral contraceptive pills. Again, they are great whenever used in the correct person, but again, we do have to make the distinction that is not a hormonal replacement therapy, that is a hormonal substitution therapy. Regardless of whether we do hormones or not, all our patients at the appropriate ages get cancer screening. So it's women getting pap smears, and pap smears really have nothing to do with hormonal cancers, but we still want to get those done on a regular basis. Women of appropriate ages need to get breast cancer screening. Typically we do those with mammograms. And if there's definitely a family history of those, you definitely want to do those a lot more often. So there's a number of types of hormonal therapy that we would typically do. Like I said, we are doing hormonal replacement therapy and not hormonal substitution therapy. And we try and use what are called bioidentical hormones. So bioidentical hormones are hormones that look exactly like what you're producing. Again, we are trying to replace sort of a one-to-one what you have lost with something else. And so again, we are trying to use hormones that look exactly like what you are producing. And there's various ways that these are typically made. Now, there are different formulations and different ways you can replace hormones. Typically in women, there are two main ways that we tend to do hormones. So progesterone can either be given orally or you can give it topically. So the skin is actually a really great organ for absorbing hormones. I tend to opt with oral progesterone for a lot of patients because most of my patients who are either perimenopausal or postmenopausal will have trouble sleeping. Progesterone, when taken orally or when ingested orally, has a really interesting and unique characteristic to it, is that one of the portions, so when it gets into the gut system, it gets cleaved, and one of the portions that it's cleaved off actually helps with sleep. So that's a benefit you get with oral progesterone versus topical progesterone. So again, for the most part, we tend to give progesterone orally, unless the patient declines or wants something else. As far as estrogen goes, now typically you can give estrogen by mouth. There are some issues that can sometimes arise from oral estrogen, and so I tend to opt for topical estrogen. And with testosterone in women, we typically tend to go topically. And when I mean topically, we are talking about either a cream that's put over the skin or what we call a pellet. So with pellet insertions, it's a tiny little pellet, size of about a rice grain with the hormones already in it that we implant right underneath the skin. So you're not having to do a topical preparation. It's a in-office procedure. We kind of just put it under the skin, set it, forget it. One of the advantages of pellets versus topicals is that with topical preparations, you have to do them on a daily basis. And typically I tell my patients, if you're gonna apply any sort of topical formulation, you need to rub that in for about 5 minutes. Maybe they'll do it for 3 if I tell them that. But with topical preparations, you really do need to get it in there, and you need to use skin that's a little thinner to allow for that absorption. I tell patients, listen, if you want to feel better, if you want to get, your energy back, your mood being better, sleeping better, things like improvement in libido, pellets will get you there faster. If you choose to do topicals, that's fine, just as long as you're aware that that could take up to about 6 months for you to get to where you need to get to. Now, one of the downsides with pellets is that once they're in, they're in. You can't really take them out. So we tend to be really conservative as far as dosing goes whenever we do the pellets for the first time on the patient, knowing full well that, hey, listen, we'd rather go a little bit lower and we can always add another pellet after we've done the labs and seen how they've done. When it comes to dosing pellets, we're really basing it on a couple of things. So we're going to look at your baseline labs. We have a calculation that looks at where your baseline labs are at. So we're going to use your labs. We actually use your age as well as your weight, because those things tend to impact your metabolism and will impact how much of those hormones you tend to utilize. We also look at what other medications you're on. And this is important because medications, so like stimulants, so if somebody is on a medication like Adderall for ADD, that does increase their metabolic rate, that increases the amount of hormones that they're probably going to utilize. So we do want to take that into consideration and potentially increase the amount of pellets that they are getting, as well as looking at activity. So patients who are not as active may not need as many pellets. Patients who are really, really active, again, just by virtue of increased activity and metabolism, may end up needing that. But again, whenever we start off, we tend to be really conservative as far as the dosing goes. We could always add in more pellets. We really can't take them out. And again, 4 weeks later, we get some labs and compare those two. I cannot overstate a lot of the benefits of hormonal optimization, both for men and women. Again, we're helping maintain muscle mass. Why is muscle mass important? The amount of muscle you have is going to determine your basic metabolic rate. So the more muscle you have, the higher your resting metabolic rate is. And that's a good thing because that's one of the ways you can start to mitigate the effects of things like diabetes or even prevent that. In women, that's also important because it's also going to help with maintaining bone mineral density, which means that you're not going to be tripping and falling and breaking a hip at 80. When you really look at patients who are falling and breaking hips, a lot of them are really not tripping on anything. They are tripping because they've lost coordination, and in part that is a function of loss of muscle mass. And so again, we really, really want to be able to help maintain bone mineral density as well as muscle mass. Again, you increase that metabolic rate, it's harder to gain weight, and again, we're all struggling with gaining weight as we age. It's a lot easier to lose the weight. We also see improvements in sexual drive and sexual function. That's a yay for most people. Cognitive function also seems to increase, as well as energy levels. So again, there are so many benefits to hormonal optimization. If you have any of the symptoms that we've been talking about, so things like weight gain, fatigue, loss of libido, brain fog, anxiety, lack of sleep, right? It could all be related to hormones, and the only way you can figure that out is by actually getting tested. We actually offer a complimentary lab testing on all our new clients where we are able to check things like the testosterone levels, the estrogen levels, progesterone, so again, your sex hormones, we check all of those. We check thyroid, we even go a little bit deeper and look at things like growth hormone, really trying to figure out if there's a problem that we can solve. Along with that, we always offer a complimentary copy of this amazing book. It is by Dr. Terry Denoy, who is an amazing clinician who I've actually learned a lot about. So along with getting the complimentary labs, you actually get a complimentary copy of this book that kind of helps you understand a little bit about what else might be going on with hormones. It delves a lot more into some of the stuff that I was talking about today. If you're trying to get an understanding of what's going on with you, what some of these labs might mean, the implications of what the testing as well as the treatments might be, this is a great and excellent resource. Again, all offered as complimentary part of our new patient panel. You can always call our office at 503-506-8500. We would be happy to chat with you a little bit more if you have any questions, or if you're ready to go ahead and get those complimentary labs done, you can sign up on the link provided. Thank you and have a great day.